Research always occurs in a larger context, so let's talk about the politics and ethics of social work research. The textbook opened the chapter with some examples of research conducted without ethics. So, for example, Nazi experiments on Jews and other prisoners. The Nazis conducted a lot of really horrific experiments, such as determining at which temperature a human being would freeze to death. Here in the United States, there was the Tuskegee study, in which African American men who had syphilis were observed over a long period of time without offering them the penicillin that could have cured the infection. So essentially letting people suffer with a curable disease for the benefit of science. Also in the United States, there was the study conducted at the Willowbrook School, where children were intentionally infected with hepatitis, so that researchers could observe the course of the disease and test the effectiveness of a particular treatment. Now, this kind of research is highly unethical, should not be done. And hopefully you're not encountering anyone trying to do this kind of study in social work. But these kind of abuses have led to more concern with ethical research. Now, in social work research, we may face a number of ethical dilemmas. Here are just a few examples. Can we pay participants for them to be in our study? Can we survey children without the consent of their parents? And can we randomize clients into an intervention and no intervention group? In other words, is it ethical to take a client who's seeking treatment and randomize them with a possibility that they will end up receiving no treatment? In each case, we have to weigh the possible outcomes and the possible ethical concerns. One document that can help guide our research ethically is the Belmont Report, which pertains to research conducted with human subjects, which is the vast majority of social work research. So the Belmont Report does not have some hard and fast rules, you can do this, not this, but it does have 3 ethical principles. The first is respect for persons, the second is beneficence, and the third is justice. So let's look at each of these individually. Respect for persons means that we treat our participants as autonomous individuals, and we allow them to make informed decisions. We give them all the information they need and then let them decide if they want to participate. As well, we may need some additional protections, such as for children or for adults with guardians. So we always have to make sure that we are respecting the people that we are recruiting into our studies. Second is beneficence, which is guided by the idea that we should do no harm. We're not going to test something that we know to be harmful on people, and we want to maximize the benefits. This means weighing the potential risks and benefits to participants in our studies, and an understanding that we should not be asking participants to take on the risk of harm if they are unlikely to experience any benefit. There should be a favorable benefit to risk ratio. And finally, justice. It's unfair to expect one group to take on the majority of the risk when a different group will realize the benefit, right? So the burden cannot fall on those who will not benefit, as it did in the Tuskegee study, where African American men were observed to view the course of syphilis, when the research that came from that study was not going to benefit them personally. And in fact, the fact that they were not treated led to many of the men to die and for their wives and children to become infected as well. There are some additional ethical requirements that need to be considered when planning any study. First, participation should always be voluntary. We can't penalize clients at an agency or refuse them services if they don't want to participate in a study being run at the agency. Participants always have the right to drop out of the study. We have to ensure that we're not going to harm the participants, and we may have to define what harm means in that context. We have to justify the cost versus the benefits to the participants. We're not allowed to deceive participants without justification for doing so, and there are some instances where deception may be warranted. And an IRB can help ensure compliance with these ethical requirements and make sure that we are behaving honestly, giving honest information to the people that we are seeking to recruit into our studies. Informed consent and informed assent are very important pieces. So an informed consent document basically tells participants the purpose of the study, who's running the study, someone they can reach with questions about the study, what kind of activities are part of the study, how the participants are selected for the study, informs participants that they have the right to stop participation at any time, covers confidentiality, privacy, and how data will be safely handled, outlines the benefits and possible harms to participants, and alerts them to any services that are provided to help them if they are harmed by the study. So generally, research with adults, the adult goes ahead and, given all this information, decides whether or not they want to participate. If you're working with minors or adults with guardians, you'll need to obtain official permission from the parent or guardian, but you should also ask the individual themselves if they agree to participate, so informed assent. They don't have the capacity to provide informed consent legally, but they can still say whether or not they want to participate. And lastly, when working with children, we need to respect parental rights. Let's talk about a couple potential ethical issues in research noted by the textbook. The first involves a case study where you're obtaining in-depth information about one or just a few participants. When you describe a person in detail, it may reveal that person's identity, even if you never use their name, right? There may be very unique aspects to their story that could identify them to some people. So we always need to inform participants that this is a possibility. And the participant should have the right to negotiate which information about them is going to be published for their own protection. Second is in a quantitative study. Even if you have a large sample, some of the demographics may reveal a subject's identity if the group is rare in the sample. Right, so even if you have 100 people in a sample, the following could happen. You could have mostly white individuals, but then provide information on a 59-year-old Pacific Islander at a Midwest group home. Now this could inadvertently reveal that person's identity. Perhaps they're the only Pacific Islander at a group home in the area. And so we want to avoid the use of small categories that may reveal identity. In this case, we wouldn't include the age and the ethnicity of the participant. Oops. Because we don't want to inadvertently identify someone. Now let's switch from ethics for a moment to politics. The socio-political climate can determine what is studied and what isn't, what studies get funded and which ones don't. There are always trends in research, and there are some hot areas that receive more funding at the exclusion of other areas. As your textbook noted, figures don't lie, but liars figure, and research can be used to mislead. So, for instance, research results may be used selectively to influence decision-making. There may be 3 studies that find that a certain intervention is harmful, and there may be one that finds that it's beneficial. So only looking at the one study that found it to be beneficial is selectively using the research. There's also the problem of selective publishing. This is a big problem in research conducted by pharmaceutical companies. So if you look at many of the published studies for antidepressant medication, most of the published studies find that the antidepressant is marginally more effective than placebo. That is, it's more effective than nothing. However, pharmaceutical companies have been known to only publish studies that show that their drug works. So they may have 3 studies published showing that a drug works, and they may have 7 unpublished studies that show that the drug didn't work. and so they didn't publish those studies because it would not make their product look good. It's hard to tell the exact extent of this because you never know how many studies someone might not be publishing. But in this case, someone did get access to many unpublished studies by a variety of different drug companies. And overall, there were more studies that showed the drugs didn't work than studies that showed that they did. This is very misleading to mental health professionals and to the general public. And these few studies that have shown the drugs to be effective have led to decisions such as the one to use medication as a frontline treatment for someone diagnosed with depression. We also have to be careful when there are one or two studies that are claimed as offering conclusive evidence on a topic. So if we use this example, 2 studies showing that an antidepressant works, this should not be taken as conclusive evidence about the effectiveness of these drugs, because there could be these other factors at play, right? Selective publishing. There's also the problem of bias. Among pharmaceutical companies, when the pharmaceutical company themselves is paying for and running a study of a drug, it tends to find the drug to be more effective than if an independent person who doesn't have a vested interest in that product runs the study, right? So there's bias introduced in a lot of different ways. This happens in all kinds of fields. I'm just most familiar with the example of drug companies. And finally, the interpretation of results may be political. This often happens with data about welfare programs, with individuals on the right end of the political spectrum looking at a study and saying, look, welfare isn't working, it's inefficient, and we shouldn't be paying people. While someone on the left side of the political spectrum may look at the same study and find evidence that welfare is a positive program and is actually helping people, and we should continue to offer it. It's really important not to overlook the larger socio-political climate when looking at research and evaluating research. Sometimes really good ideas and really good research simply isn't paid any attention to because of these socio-political factors. So I'm going to offer an example from, not from social work, but from medicine. You are going to meet Ignaz Semmelweis, a Hungarian physician living in the 1800s. We're going to listen to this piece by National Public Radio, and it will serve as an illustration of how the context and the factors surrounding research can have a huge impact, perhaps more so than even the research itself.
Today in our segment, Your Health, we're going to hear about one of the most important advances ever in human health. The revolutionary combination of water and soap and hands. You might be rolling your eyes, but really, hand washing is still considered the #1 defense against the spread of germs. Let's hear this morning the story of the physician who realized the importance of clean hands well before anyone knew about germs. NPR's Rebecca Davis has our story.
This is the story of a man whose ideas could have saved a lot of lives and spared countless numbers of women and newborns feverish and agonizing deaths. You'll notice I said could have. The year was 1846, and our would-be hero was a Hungarian doctor named Ignaz Semmelweis. Now, Semmelweis was what you might call a man of his time. Justin Lessler is an assistant professor at Johns Hopkins School of Public Health. He says, in those days, doctors like Semmelweis were trained to approach medicine scientifically.
This is the start of the golden age of the physician-scientist, where physicians were expected to have scientific training and some scientific understanding.
So doctors like Semmelweis were no longer thinking of illness as an imbalance caused by, say, bad air or evil spirits. They looked instead to anatomy. Autopsies became more common, and doctors got interested in numbers and collecting data. The young Dr. Semmelweis was no exception. When he showed up for his new job at Maternity Hospital in Vienna, he started collecting some data of his own. Justin Lessler says Semmelweis wanted to figure out why are so many women in maternity wards dying from something called childbed fever. First, he compared 2 maternity wards in the hospital.
One of the things he did was count up the number of patients and the number of deaths that occurred in the first clinic, which was staffed by almost all male doctors and medical students, and the number of deaths that occurred in the second clinic that was staffed by almost all female midwives.
Semmelweis crunched the numbers and discovered that women in the clinic staffed by doctors and medical students died at a rate nearly 5 times higher than women in the midwives' clinic. But why?
He went through and he, started ruling out ideas.
And right away, he discovered a big difference in the 2 clinics. In the midwives' clinic,
women gave birth laterally or on their side. In the doctor's clinic, women gave birth laying on their backs. So he had the women in the doctor's clinic give birth lying on their side.
And?
No effect.
Then he noticed that whenever someone on the ward died of childbed fever, a priest would walk slowly through the doctor's clinic, past the women's beds, and there'd be an attendant ringing a bell. This time, Semmelweis theorized
that priest and the bell-ringing attendant so terrified the women after birth that it sent them over the edge and they'd develop some fever and, get sick and die.
So Semmelweis had the priest change his route and ditch the bell. And
it had no effect.
By now, Semmelweis is frustrated. He takes a leave from his hospital duties and travels to Venice. He hopes the break and a good dose of art would clear his head. Professor Jacqueline Duffin teaches history of medicine at Queen's University in Kingston, Ontario. She says when Semmelweis got back to the hospital, some sad but important news was waiting for him. A colleague of his, a pathologist, had fallen ill and died.
This often happened to pathologists. There was nothing new about the way he died. He pricked his finger while doing an autopsy on someone who had died of childbed fever.
And then he got very sick himself and died. Semmelweis studied the pathologist's symptoms and realized the pathologist died from the same thing as the women he autopsied. This was a revelation. Childbed fever wasn't something only women in childbirth could get sick from. It was something other people in the hospital could get sick from as well. But this still didn't answer Semmelweis's original question. Why were more women dying from childbed fever in the doctor's clinic than in the midwives' clinic? Jacqueline Duffin says the death of the pathologist offered him a clue.
The big difference between the doctor ward and the midwife ward was the fact that the doctors were doing autopsies and the midwives weren't.
So he hypothesized that there were cadaverous particles.
Little pieces of corpse, basically.
The doctors and medical students were getting on their hands from the cadavers that they dissected. And when they delivered the babies, they would get the particles inside the women who would eventually develop the disease and die.
If Semmelweis's hypothesis was correct, getting rid of those cadaverous particles should cut down on the death rate from childbed fever. So he ordered his medical staff to start cleaning their hands and instruments, not just with soap, but with a chlorine solution. Chlorine, as we know today, is about the best disinfectant there is. Semmelweis didn't know anything about germs. He chose the chlorine because he thought it would be the best way to get rid of any smell left behind by those little bits of corpse.
When he imposed this rule in his ward, the rate of childbed fever fell dramatically.
And you'd think everyone would be thrilled. Semmelweis had solved the problem. But they weren't thrilled. For one thing, doctors were upset because Semmelweis's hypothesis made it look like they were the ones giving childbed fever to the women. And Semmelweis was not very tactful. He publicly berated people who disagreed with him, and he made some influential enemies. Eventually, the doctors gave up the chlorine hand washing, and Semmelweis lost his job. Even so, he kept trying to convince doctors in other parts of Europe to wash with chlorine, but no one would listen to him. Over the years, Semmelweis got angrier and eventually even strange. There's been speculation he developed a mental condition brought on by possibly syphilis or even Alzheimer's. In 1865,
he was only 47 years old.
Ignaz Semmelweis was committed to a mental asylum.
The story goes that he was probably beaten. Regardless, in the end, he died of sepsis a little while after being committed.
And sepsis, as it turns out, is basically the same disease Semmelweis fought so hard to prevent in all those women who died from childbed fever. Rebecca Davis, NPR News.
And now here
Now, I realize this is a somewhat disheartening story, but it provides a great example of some of the other things that can get in the way of a good idea and good research. And this applies today, right? So many agencies, professions, individuals may be resistant to some kind of finding if it somehow implicates them as being complicit in bringing about some negative outcomes, right? We all have our biases. We don't really like being presented with information that challenges what we already believe. So we have to always try to critically evaluate what we already know and any new information. And this is a tragic example with this physician who came up with a really simple method that could have saved countless lives, but he wasn't listened to because of how he presented his findings and because other physicians felt that he was blaming them. His idea was completely disregarded, even though it had been shown to dramatically cut the death rate on these maternity wards. Now, it's really easy to look backwards in time and see these egregious examples where a really good idea was overlooked and someone just wasn't listened to because it went against the prevailing wisdom of the time. It's harder to see when and where this may be happening today. So that's my challenge to you, is to always keep an eye out for what is perhaps being overlooked now. Are there good sources of evidence, good studies that we're not listening to for some socio-political reason? And in doing this, we can try and ensure that we are always paying attention to the best available evidence and making decisions based on it, and making decisions that are in the best interest of our clients.